Welcome to Altered Ventilation and Diffusion. Here we're going to talk about ventilation and diffusion and specific exemplars related to alterations of such. We will take this back a bit to look at the function of the lungs, how they are controlled. Some of this we can bring forward from last week, such as the effects on the lungs by the autonomic nervous system. With the parasympathetic nervous system, there is airway constriction. We also have increased secretions. Here, we have the muscarinic receptors, which promote that constriction. With the sympathetic nervous system, there is bronchodilation. We also have decreased secretions. Here we have the beta-2 receptors in the lungs that promote dilation. In addition to facilitating gas exchange, we have the inactivation of vasoactive substances like bradykinin, which is an inflammatory mediator that dilates arterioles and causes a decrease in blood pressure. There is also the conversion of angiotensin 1 to angiotensin 2. Remember that this is a potent vasoconstrictor that causes an increase in blood pressure and works with the RAS system. Here there's a total of 4 presentations covering alterations in ventilation and diffusion. This presentation will cover the basics of ventilation and diffusion and general manifestations and management of alterations of such. The next 3 sections of this presentation will go into the specific disease processes or exemplars such as pneumonia, asthma, chronic bronchitis, and emphysema. Here is just a brief review of the respiratory system. The major function here is to facilitate the exchange of gases from outside the body and in the blood. The respiratory system is composed of the lungs, airways, and structures of the pulmonary circulation pathway. The upper airway is composed of the nose, mouth, nasopharynx, and the oropharynx. The laryngeal pharynx connects the upper airway to the lower airway, which is composed of the trachea, bronchi, and bronchioles. At the very end of the bronchioles are the alveoli. The alveoli play an important role in gas exchange. This is where the oxygen and CO2 exchange takes place. We can see there are alveolar structures and their roles. This will become more important later as we discuss the specific disease processes, especially emphysema. Surfactant is synthesized by type 2 alveolar cells. It lines interalveolar surfaces. The effects of surfactant on lung inflation include the lowering of surface tension, increasing lung compliance, making for easier inflation, stabilizing and evening the inflation process. It also helps to keep the alveoli open. Lung compliance is another component to this. This is the ease with which the lungs can be inflated. It is determined by the lungs' elastic properties, water content, and surface tension. Elastic recoil is the lung's ability to recoil to the original position after the stretch of inspiration. Some airway resistance is normal, but small changes in airway diameter will significantly increase resistance. Also, secretions can narrow airways, and we can still have bronchoconstriction here, which also narrows the airways. This can all prevent adequate gas exchange. Ventilation involves both inspiration and expiration. Inspiration is the breathing in to acquire oxygen. Here, air movement is unidirectional from an area of high pressure to low pressure. The chest cavity size changes to alter the pressure gradient and allow for lung expansion. With expiration, we have the removal of carbon dioxide out of the body through the lungs. To do this, the diaphragm and external intercostal muscles relax, and the lungs compress and increase the pressure inside the airways to expire the CO2. The rate and volume of ventilation is controlled by the central nervous system, the respiratory control center in the pons and medulla. It sends neuronal impulses to tell the body structures what to do, and a lot of this is based on the activation of the parasympathetic nervous system or the sympathetic nervous system. There are also lung receptors within the epithelial and smooth muscles of the airways. They are responsible for sensing changes and initiating an appropriate response, be it a coughing response or an expiratory response. Then we have the chemoreceptors, which detect gas exchange needs based on our PaO2 and PaCO2, as well as pH levels. Remember that if there is too much pH, we will increase the respiratory rate to blow off the CO2. And if there is too little, we will decrease the respiratory rate in order to retain the CO2 to bring the body back to a state of homeostasis. We have different measures and parameters we can use to measure the effectiveness of respirations and expiration. These measures would be a part of a pulmonary function test. We look at spirometry values. Spirometry measures the rate at which the lung changes volume during forced breathing maneuvers. We also look at lung volumes and lung capacity. Tidal volume is the amount of air that is exhaled after expiration. Typically, it is about 500 mLs in an adult. Vital capacity is the max amount of air that can be moved in and out of the lungs with inspiration and expiration. Forced vital capacity is the max amount of air that can be exhaled. Residual volume is the volume of air that remains in the lungs after expiration. Total lung capacity is the amount of air in the lungs when they are fully expanded. These values are important to detect, follow, and manage patients with lung disorders. So here we have oxygen and carbon dioxide that are exchanged at the alveolar capillary junctions. Pulmonary gas exchange is dependent on three factors: ventilation, perfusion, and diffusion. Here, two major processes occur. Oxygen is trying to get to all of the cells, and carbon dioxide is trying to escape through the lungs. The effectiveness is going to depend on partial pressure and solubility of gas, and the thickness and surface areas of the membranes. In regards to diffusion, we talked about ABGs, about the PaO2 and the PaCO2. This Pa, which is partial pressure, is the collision of oxygen and carbon dioxide, and this creates pressure, which we measure in millimeters of hemoglobin. Partial pressure of oxygen, remember, in the arterial blood is the PaO2, and the partial pressure of carbon dioxide in the arterial blood is the PaCO2. Most of the oxygen that is carried in the blood is bound to hemoglobin, which is found in the red blood cells, or erythrocytes. The binding of hemoglobin is determined by the partial pressure of oxygen and the affinity of hemoglobin for oxygen. The amount of oxygen that is bound to hemoglobin at normal arterial PO2 values is determined by the amount of oxygen, the amount of hemoglobin that is present. Iron is what pulls oxygen into the hemoglobin molecule. So what if you have an iron deficiency? How do you think this will affect oxygen levels? Our oxygen levels are then going to be low. So then think about what is going to happen to the respiratory rate. Your breathing rate will increase as your body tries to get more oxygen. Just as an example, this is why shortness of breath is common in patients who have iron deficiency anemia. CO2 is a major waste product of cellular functions. So if we have conditions that decrease CO2 elimination, what will that effect be? Ultimately, we will have an acidotic state. So what do you think our respiratory rate will be typically in an acute state? Typically, with a respiratory acidotic state, you will have hypoventilation. Remember that in respiratory acidosis, the patient's pH is less than 7.35 and his PaCO2 is above 45, the upper limit of normal. Alveolar hypoventilation is the only mechanism that causes hypercarbia, or a PaCO2 above the normal upper limit. The amount of alveolar ventilation necessary to maintain normal PaCO2 varies depending on the amount of CO2 that is produced. So here are a few instances where we can have altered ventilation and diffusion. With ventilation, there is a problem of blocking the airflow in and out of the lungs. The lungs will either be ventilated but not perfused, and we may have dead airspace, like with a pulmonary embolism or low cardiac output. Or the lung is perfused but not ventilated. Here, perfusion without ventilation is essentially circulation without oxygen. This could be caused by pneumonia or pulmonary edema. Here, two major mechanisms are implicated: the compression or narrowing of the airways and disruption of the neuronal transmissions needed to stimulate the mechanics of breathing. With impaired diffusion, there is a restricted transfer of oxygen or carbon dioxide across the alveolar capillary junction. This is going to depend on solubility and partial pressure of the gas and the surface area and thickness of the membrane. Alterations in either state can lead to hypoxemia, decreased oxygen in the arterial blood that leads to a decreased PaO2, and hypoxia, which is oxygen deprivation in the cells, as well as hypercapnia, increased carbon dioxide levels in the blood. This ultimately leads to cell injury and cell death. So what are our general clinical manifestations? Cough, mucus production, hemoptysis, dyspnea or shortness of breath, orthopnea, adventitious lung sounds. Adventitious lung sounds are abnormal sounds that are heard when auscultating a patient's lungs and airways. These sounds include abnormal sounds such as fine and coarse crackles. Crackles are also called rales, wheezes, perhaps bronchi, pleural rubs, and stridor. They're going to vary depending on the underlying cause. The use of accessory muscles. Here, muscles other than the diaphragm and the intercostal muscles may be used with labored breathing. The sternocleidomastoid, spinal, and neck muscles may be used as accessory muscles of respiration. Their use is a sign of abnormal or labored breathing. Patient may also have chest pain. You may see a barreled chest in patients with long-standing alterations in ventilation and diffusion. It occurs because the lungs are chronically overinflated with air, so the rib cage stays partially expanded all the time. This makes breathing less efficient and aggravates the patient's breathing patterns. Systemic manifestations may occur, such as a fever, especially with an underlying acute process. A mnemonic can help you remember some of these clinical manifestations. Diaphragm, which represents diaphoresis, hypoxia, respiratory rate, gasping, and accessory muscle contraction. In addition to a patient history and physical assessment, we can perform some or all of the following tests depending on the presenting symptoms and disease process occurring. The pulmonary function test, again, will help detect, follow, and manage patients with lung disorders. ABGs will be used to detect acid-base imbalances. A pulse ox can be used to non-invasively monitor oxygen saturation. Diagnostic tests such as a bronchoscopy, X-ray, CAT scan, MRI, or nuclear medicine studies may also be used depending on the underlying processes or alterations that are occurring. A culture and sensitivity of the sputum to determine if there is an infectious process, if this is indicated. And perhaps a thoracentesis. A thoracentesis is a procedure in which a needle is inserted into the pleural space between the lungs and the chest wall. This procedure is done to remove excess fluid. This excess fluid is also known as a pleural effusion. Here we can remove the fluid for diagnostic testing, as well as therapeutically to help alleviate some of the difficulty the patient is experiencing while breathing. So treating impaired ventilation and diffusion. The treatment will depend on the cause and the exact disease process. In addition to these interventions here, we will be looking at specific medications to treat ventilation and diffusion disorders. Our main goal here is to remove any obstruction and maintain the integrity of the airway. Specific medications we will use are going to help decrease inflammation and mucus. We will begin to speak about some of those in one of the following presentations. The provision of supplemental oxygen as needed, and control of infectious process. We will speak more about antibiotics later in another presentation. Remember our ABG results. This is an important diagnostic test in creating and evaluating treatment plans. In the next presentation, we're going to begin to look at the disorders.